you very much for a nice introduction. So I am going to present on the experience of intrauterine transfusion in our centers, which has been performed for the last 7 years. So just giving you highlights what we have done. Okay. Okay. Now, do you see the next slide? Do you see the next slide?
Yes, Prof. We are seeing your slides. You can proceed.
Okay. Okay. So as outlined, as you see, this is what I am going to describe. Okay, what are the most common indications? I'll give some introduction to alloimmunization, since this is the most common indications, and the rest. So the most common indications that were for intrauterine transfusion was severe fetal anemia because of alloimmunization. Almost more than 99% of intrauterine transfusion were performed because of alloimmunization, so severe anemia due to alloimmunization. And only few were done for severe fetal anemia because of other causes. Why alloimmunization is common in our country in Africa? So just to give you a highlight, okay, insufficient supply of anti-D, despite it is being on the WHO list of essential medicines. If it is available, we may be due to high burden of activities, we may be forgetting to give medication during antenatal care, after delivery or abortion care. If it is available, it might be too expensive and we may not buy it. Some anti-D products might be ineffective, since there are mono and polyclonal anti-D vaccines. So in our country, most of the time, the monoclonal is available. So we don't know whether one of them are effectively covering the immunization. So geographical differences in access, coverage, awareness among healthcare providers or communities widely. There are big discrepancy in our continent. War and other forms of armed conflicts are all over a majority of African countries, so this may affect. Lack of resist testing in pregnancy is widely common in most of our continent, so inappropriate blood transfusion is another thing that can be common causes. So since alloimmunization is a common cause of severe fetal anemia needing intrauterine transfusion, I will give some introduction to alloimmunization. So maternal red blood cells alloimmunization is the leading cause of fetal anemia and is responsible for fetal and neonatal morbidity and mortality. Hydrops fetalis and intrauterine and perinatal days are most severe consequence of alloimmunization. Intrauterine transfusion has been the mainstay of treatment of fetal severe anemia, which occurs as a result of alloimmunization since the early 1980s. Nowadays, perinatal survival rates can exceed 90% if anemia is diagnosed and treated in early stages of experienced centers. So 10% of pregnant women are considered to be Rh negative in Ethiopia. So I assume in the majority of African countries, it is similar between 8 and 10. Inadequate supply of anti-D prophylaxis is a major problem in our continent, despite this is WHO essential drug list. If it exists in some of the big cities, it is going to be very expensive and unaffordable for the majority of our pregnant women. According to the World Health Organization estimate, Ethiopia is one of the most leading countries having high perinatal mortality. So autoimmune hemolytic disease of the fetus and fetus is a condition in which the red cells of the fetus or newborn are destroyed by maternally driven alloantibodies. These antibodies arise in the mother as a direct result of blood group incompatibility between the mother and the fetus. So there are many different antibodies which can cause severe fetal anemia. The most common are red blood cell system, ABO blood system, and minor red blood cell antibodies. So when severe anemia occurs in the fetus, we are talking about erythroblastosis fetalis. When it occurs in the newborn, we are talking about hemolytic disease of the newborn. So maternal red blood cell antibodies develop as a result of exposure to foreign red blood cell antigen through chronic transplacental fetal-maternal hemorrhage as a result of miscarriages, ectopic pregnancies, stillbirths, or deliveries are the most common cause of RH immunization. So this may lead to associated complications during subsequent antigen positive pregnancy. So once the woman is alloimmunized, so in subsequent pregnancy, if the fetus is Rh positive, then that fetus will be at risk of developing anemia. So naturally occurring red blood cell antibodies are those which occur in the absence of exposure to foreign blood, like anti-M, anti-N, and anti-A and anti-B are commonly found without having any significant exposure. So naturally they are occurring in our red blood cells in the plasma. So anti-M and anti-N may result from exposure to viruses or bacteria and are present in 2 to 3% of general population. So sometimes these antibodies may cause hemolytic disease of the fetus and newborn, especially when the mother is Rh, A or B group, and the fetus is, when the mother is O and the fetus is A or B, so naturally occurring antibodies in the mother can cause destruction of the red blood cells of the fetus, especially in the neonatal period. So how we are going to diagnose hemolytic, this severe anemia in women with alloimmunization? So the mainstay of diagnostic method in our center is Doppler. So Doppler ultrasound is the mainstay. In this Doppler ultrasound, we use the peak systolic velocity in the middle cerebral artery to predict fetal anemia. So when the peak systolic velocity of the middle cerebral artery is greater than 1.5 multiples of the median for the corresponding gestational age, in that case, that predicts moderate to severe anemia with the sensitivity of 88% to and with a negative predictive value rate of 89. So it is a very significant diagnostic modality in detecting fetal anemia. So as you see here, the way how we do it is, okay, we will hold on ultrasound, and then we impose sample volume with 1 millimeter on the middle cerebral artery, 2 millimeter from its origin from the internal carotid artery. Then the ultrasound beam should be parallel to the direction of blood flow. In that way, the angle between the ultrasound beam and the direction of blood flow should be 0 degrees, but we can tolerate up to 20, okay? Below 20, up to 20 and below 20, if possible, 0 is the best to measure the peak systolic velocity. In that way, we will measure the peak systolic velocity accurately, and we will have the degree of detection of fetal anemia in the high percentage. So this is a graph where the red line demonstrates that 1.5 moms of the, multiples of the median. If that measurement that we receive peak systolic velocity, what is in the fetus affected with fetal anemia, is found to be measured, then we divide that with that of the peak systolic velocity of the normal baby with the corresponding gestational age. In that way, we will get these multiples of the median. If it is going to be 1.5 and above, then that baby is at risk of severe fetal anemia. If it is between A and B, moderate anemia. If it is below B, mild anemia. If it is at median curve or below, the fetus is normal without anemia. So how we are going to manage fetuses with alloimmunization? So it depends on whether the pregnancy is the first time affected or multiple time affected. So in the cases of first affected pregnancy, serial antibody titers are very important to determine the risks of anemia. So we are going to do this every 4 weeks until 24 weeks of gestation, as long as the titer remains below the critical titer, which will assess the risk of development of hydrops fetalis when it ranges between when it is going to be above 32. So titers will be repeated after 24 weeks, every 2 weeks. Then when the critical maternal titer is reached, usually in our center, we use from 16 to 32. We will proceed to the next step. What is that step? So it is peak systolic velocity Doppler study. So the peak systolic velocity of the MCA study will be initiated at 24 weeks of gestation. Then, depending on the trend, it will be repeated every 1 to 2 weeks. If the peak systolic velocity of middle cerebral artery is greater than 1.5 multiples of the median, then that is an indication to sample the blood from the umbilical vein. So chondrosynthesis should be done. If the peak systolic velocity of middle cerebral artery value is less than 1.5 multiples of the median, and the gestational age is 35, in that case, we have to do amniocentesis at the same gestational age, 35 weeks, to determine the maturity of the lung of the fetus. If the maturity of the lung of the fetus is present, in that case, then we have to induce pregnancy after 2 weeks after 2 weeks. So that means at 37 weeks of gestation, it will be ended with delivery. If the results indicate that fetal lung is immature, and at the same time the peak systolic velocity is demonstrating less than 1.5 multiples of the median, in that case we have to repeat the amniocentesis after 2 weeks of gestation. And if it is mature, then we can proceed with induction of labor. If it is not mature, depending on the trend of the peak systolic velocity measurements, we can push it up to 39 weeks of gestation. So if the pulmonary immaturity is noted at the time of 35 weeks of gestation, and at the same time the peak systolic velocity middle cerebral artery is greater than 1.5 multiples of the median, which demonstrates severe fetal anemia, in that case we have to administer to the mother phenobarbital 30 milligram orally, TID basis. Then we will induce after 1 week of gestation. In that way, we will decrease the chance of neonatal exchange transfusion. So phenobarbital will be used to mature the fetal liver. So we were talking about when the fetus is affected first time. Now, when there is history of previous perinatal loss or previous need for intrauterine transfusion or previous need for neonatal exchange transfusion, in that case, the pregnancy is already previously affected. The management is different. In that case, maternal titers are not needed to be done. It is not predictive of the degree of fetal anemia. It should not be done. Then we should proceed directly to the determination or evaluation of the middle cerebral artery by Doppler study. So in that way, when the middle cerebral artery Doppler study demonstrates MOM 1.5 and above, then we proceed with sampling of the umbilical vein. If the umbilical, the blood demonstrates that the hematocrit is less than 30%, then we have to proceed with intrauterine transfusion. So the blood that we are going to use for intrauterine transfusion should be freshly donated. It should be cytomegalovirus negative unit of type, or if possible, in our country, we do not screen cytomegalovirus. We screen only for HIV, hepatitis B, C, and syphilis. The blood should be Rh negative, red blood cells. It should be cross-matched with the maternal blood sample before we administer the blood to the fetus. And if possible, it should be leukoreduced. It should be irradiated. But in our case, the blood will not be irradiated in our national blood bank. It should be washed. It should be packed to the final hematocrit 75 to 85. In our case, most of the time we receive blood between this range, sometimes even above 90%, which is very good to prevent volume overload in the fetus when we administer the transfusion. The final hematocrit that we are going to target should be between 40 and 45. And it should be repeated every 2 weeks until suppression of fetal erythropoiesis is going to occur. The degree of decrement per day after transfusion is between 0.8 up to 1%. In that way, we can arrange our next interval of intrauterine transfusion. The most important thing here is, especially in the second trimester of pregnancy, when we give intrauterine transfusion, we should be very careful not to exceed fourfold that of the hematocrit of the fetus sampled before the intrauterine transfusion. What does mean this? This means if the hematocrit of the fetus is 4 at the time of sampling, then we should not give more than fourfold of that. That means the maximum target should be 4 times 4, 16. Then after 48 hours, we can repeat until we reach to the final hematocrit, the appropriate one, 40, 45. This is in that way we will reduce the overload of the fetal heart, not to be a problem to the fetus. So now I will give you 7 years of data analysis to cases that we have administered intrauterine transfusion. So totally we performed 130 intrauterine transfusions, but we could not manage to assess all because 61 cases of IUTs were registered in a logbook, which has been lost. So we managed to assess 108 cases of alloimmunization cases. Out of these, 98 had previous history of alloimmunization, which is 90.7%. And out of these 108, 10 of them had first-time sensitization during the pregnancy. So out of these 108 cases, 70 of them had peak systolic velocity of middle cerebral artery more than or equal to 1.5 multiples of the median, for which indication was there to do chordosynthesis. Not to all, but we did to some based on the gestational age. So among 70 cases with middle cerebral artery peak systolic velocity above 1.5 multiples of the median, 41 of them received intrauterine transfusion. So when we see this graph for 41 fetuses, we gave 69 intrauterine transfusions. The median number of intrauterine transfusion per fetus was 2. The maximum was 6. The minimum was 1 intrauterine transfusion. The earliest gestational age at the first intrauterine transfusion was 24 weeks plus 4 days, and the latest was 35 weeks plus 0 days. So after 35 weeks, we do not give intrauterine transfusion, even though the fetus is anemic. So the overall discharged neonates after intrauterine transfusion was 91.1%, which demonstrates with the significance of very high significance after giving intrauterine transfusion. So you can see here 41 of them were received intrauterine transfusion, and 29 of them did not receive transfusion, either because by the time they arrived or we diagnosed, it was after 35 weeks of gestation, or the placenta was posterior and the umbilical vein was not accessible, and so on. So because of that, this group of fetuses did not receive. And then we have compared the outcome of these two groups. As you can see, those who received intrauterine transfusion have a good outcome with a significant pattern. So and this graph shows you those fetuses with hydrops and those fetuses without hydrops. Overall, those received intrauterine transfusion, not received intrauterine transfusion, and in the other group also the same. So we try to compare the two groups. So the one with without hydrops has a very significant good outcome, especially in terms of discharged home newborns, where in the non-hydrops group was 95.1. In the hydrops group was 58.3. So so it was a very significant difference. So here we compared out of 41 cases of fetuses who received intrauterine transfusion. We grouped them into two, those without hydrops and those with hydrops. And both of these groups received intrauterine transfusion. So since the hydropic in the hydropic group, the newborns, so the neonates were very small in number, there was a statistically significant difference in terms of discharged home 91.4 in the non-hydropic group, and the hydropic group 66.6. Most likely, if this number of cases with hydrops, if their numbers are going to be very high and they are going to receive appropriately intrauterine transfusion and diagnosed early, most likely the discharge of the neonates might be comparable. But in this case, since our numbers are very small, it has shown significant difference. So the overall survival of neonates affected with alloimmunization was 96.7%. So out of 41 fetuses transfused with intrauterine transfusion had a hematocrit of less than 30% by the time of chordosynthesis. 6 of them had either 30 or above, So our detection rate using the middle cerebral artery was 85.4% for severe fetal anemia. So when we see the newborns or the neonatal outcome, out of 41 fetuses, 42 of them received phototherapy, and 31 of them required exchange transfusion. So in detail, the 5-year cross-sectional study was done and published in International Journal of Women's Health. Those of you who are interested, you can just copy this link and you'll get the published paper from our center. So the challenges that we had during this course of management, most of the time we could not get O negative blood at the time we needed, but it was not easy. With multiple communication, we managed to get. Most of the time that is the case. Now we have managed to have a group of WhatsApp group of O negative individuals. So when we need, we communicate with them, and it becomes somehow easier. So supply of IUT sets was also problematic, but now we managed to secure IUT set for the intrauterine transfusion. And another challenge is when the placenta is posterior, because of access to the umbilical vein might not be easy. And when you access it, because of the movement of the baby until you give the cranium, sometimes severe damage can occur. So that's a big challenge for us sometimes. So point of care hematocrit testing is not currently available in our setting. Once it was available, but the kits sustainably to make it available is not easy. So when we draw blood, we take it into the lab, and someone will determine. So one person will stay in the laboratory, another one. So with telephone communication, we will try to know the initial hematocrit of the babies, and based on that, we continue to give blood. So the way forward, so since our immunization is a big problem in our continent, it is very important that universal screening through innovative and affordable tests to determine the actual prevalence of rhesus negativity should be a very big way forward to be done. And public education on rhesus disease, its associated morbidity, mortality, and potential for its prevention should be widely done in collaboration with concerned stakeholders. We have to push our governments and other stakeholders to address gaps in access and coverage of prevention of anti-D immune globulin. We should work with health training institutions to enhance provider awareness in prevention and management of rhesus disease. We have to develop skills through training, through maternal fetal medicine fellowship program. So our center was the first to start this fellowship program. Now, after graduating many of our fellows, similar services being provided at one an additional center in Addis Ababa. So Blackline Hospital is also providing, Yekatis Hospital is providing, another out of Addis Ababa, the one who trained with us, is also providing the similar services at Bahar Dar University. I think these three centers are now providing. So these kinds of skill should be developed, and provision of intrauterine transfusion should be widely available until we are going to be effectively covering with prevention, with administration of anti-D. Referral of fetuses with severe fetal anemia to tertiary care center with expertise is very important. Where mothers are immunized, care refers them to the right expertise of care, working with key stakeholders to enhance uptake of antenatal care and skilled birth attendants. Another very important issue, strengthening data collection and applications to inform best practices, advocacy, and policy is the way forward to address this and other priority issues. So, saying this, Ethiopian Society of Obstetricians and Gynecologists will held annual conference in 2024 in February. So from 16 to 20. So you are welcome. You are invited to attend our conferences or to be part of the webinar sessions. So I will call upon all of you to be part of these important conferences. So if there is time, I can share one case. If not, I will finish with this one. Thank you very much. Hello, can you hear me?
Yes, yes, we can hear you, Prof. Thank you, thank you. This is quite these days. I'll be in Ethiopia to witness one of these intrauterine fetal transfusion. I haven't seen one. All right. I think the admin can put up our list of program for the afternoon so that people may ask questions. The floor is now open for questions. Let me view the chat box. Dr. Rosa, Prof. Abdullah, your team at St. Paul's Hospital. Impressive work. Yes, indeed, it's quite impressive. Fetal medicine, very impressive work. All right, the floor is now open for questions.
I have a question. This is Rosa from Kenya.
You may go ahead, Dr. Rosa.
Yeah, I would like to ask, this is really, really impressive. I'm even thinking we may need to benchmark with your hospital, Professor. Is there a particular set for IUT that you have, and which company do you procure it from, or you usually reconstitute that?
For IUT sets, you mean?
Yes, I mean the IUT set. Do you have an already prepared set, like the way epidural set would come? And which company do you
Okay.
use?
Yeah. So at the beginning, we were using the spinal needle, and it was not always good, especially in cases of placenta when the placenta is posterior. So now we managed to secure a needle from China, one company. So imported some a good number of needles and the test. I mean the connecting tube in the 3 ways. So if you are interested, I may share you the company that with which I was communicating. So for the time being, we have enough, but in the future, I think still communication with the same company, but it is not available in Ethiopia. We communicated through email, and then managed to buy and then import it. Yeah.
Thank you. I'll reach out to you for that.
No problem. I will. My email. I can. My WhatsApp number can be. You can find it in the fetal. In the fetal. This WhatsApp group.
Maybe, Prof, for the benefit of all of us, if you may kindly share the company in the WhatsApp group.
I will share you.
All right, thank you. There's a hand there. Fabian Obakau. Is it an old hand or a new one? You can go ahead, Dr.
Yes,
Fabian.
sir.
Yeah, you can go ahead.
Thank you, sir. Good afternoon, everyone. I have a question for Dr. Kiba and Dr. Abdulkadir. For Dr. Kiba, I had concerns why he was dating pregnancy in months, even though he tried to explain that most women would come to tell you their GA in months, but it was better to convert in weeks, because you can have someone saying about 4 months or 4.5 months. So how do you translate that if he puts everything in months? But if it's in weeks, you can convert the months to weeks. Say, for instance, if you have 4 months, in obstetrics, that would be 17 weeks. So, but if all the analyses were in months, you may lose out some patients that have in between, like 4.5 months, 5.5 months. So that would have been better, dating the pregnancy in weeks. So he had a slide that showed the World Health Organization recommendation to have the first scan at about 24 weeks. So at a point, he was still saying 26 weeks. So which one is more appropriate? Because he was saying 6 months. 6 months in obstetrics is 26 weeks. Why WHO recommendation was 24 weeks. So which is more appropriate if in his work? Because he said his work was in tandem with WHO recommendation. Then for Dr. Abdulkadir, he requested to have a case study shared with the House. I don't know if that is possible, to see how that case was managed. Thank you, sir.
Okay, so the cross-sectional 5-year cross-sectional study, I can share through this WhatsApp group. You can have it.
Thank you, sir.
Yeah, you are welcome. So you are from? Where are you from? Okay, so the one who was the Kenyan who asked me in the first. Okay, just recently we had one case came from somewhere near Nairobi. So she came at 23 plus something weeks of gestation, and we managed to give her 5 routes of intrauterine transfusion until she becomes 32 plus 2 days. Just last week, she traveled to Kenya. So just this is for your information. The one Kenyan asked me about. So even from Kenya, they came to our center to receive intrauterine transfusion.
We are actually, Professor, we are in communication with this particular patient, and we are following her progress very, very closely.
Very much. So I am very interested. Okay, if you already are following about her case, I think most likely at 34 weeks of gestation, the fetus will be most likely anemic, because at the time when we give her blood, it was 42%. So in her case, we noticed that 0.8 hematocrit per day is a decline. So by 42, by 36, by 35 weeks, her hematocrit will be, I think, less than 30. It will be less than somewhere 20 something, 25 or so. So I think phenobarbital, she should start phenobarbital, 30 milligram TID basis. And then after a week, better to terminate the pregnancy.
No problem. I'll get that information to her.
For exchange transfusions, then should be ready, fine.
Okay.
Or 34 is also fine, yeah.
Okay.
Thank you very much.
Thank you as well.
Yeah, the other question, I think it was directed to Dr. Sisai Keba about using months in a pregnancy.
Okay, thank you. So of course, dating pregnancy in weeks is more precise, and that's the one to describe the duration of the pregnancy more precisely. And if that's available, that's the one we use. But for this study, this was a cross-sectional survey. So we selected pregnant mothers having antenatal care at hospitals, and we asked them the time they had their first antenatal care and the time they had their first obstetrical ultrasound. And as I have tried to explain, our patients usually mention the duration of pregnancy in months and usually do not remember the exact duration of the pregnancy in weeks. That was the problem. Otherwise, of course, dating the pregnancy in weeks is more precise. So if you randomly ask a pregnant woman at antenatal care what was the gestational age of the pregnancy, almost 100% of them, they will tell you in months, and they do not know specifically in weeks, unless only few of our patients remember it in weeks. That's the reason we preferred the description of the gestational age in months rather than in weeks. And the WHO recommendation is from antenatal care guideline, which was published in 2016. And at the time of our study, that was the latest recommendation we have based on the duration of the pregnancy in months, which specifically recommends any pregnant woman who is having antenatal care should have her first ultrasound, obstetric ultrasound, before 24 weeks. That's exactly the recommendation from WHO, which was published in 2016. And we preferred that definition for the reasons as I have explained. The first is because it specifically says labels 24 weeks as 6 months, which is not exactly precise, but for survey purpose, on the logbook, on the WHO logbook, it says in the first 6 months, and it specifically says before 24 weeks. And that was the WHO guideline we have chosen so that we can assess it in our setup, because one, our patients remember it in months. Two, WHO provides recommendation for general setups like ours with limited availability of obstetric ultrasound. Of course, the WHO study did show that ultrasound in the first trimester is very important, but taking multiple factors like availability, the presence of professionals who do the ultrasound and the like, the WHO recommended any pregnant woman should have her first ultrasound before 24 weeks, and that's why we used that as for the definition of optimally timed first prenatal ultrasound.
Thank you, Dr. Akiba. I can see Dr. Femi Olemidi. Your hand is up. You can go ahead. Okay, maybe it was an odd hand. Okay.
Can I ask, 1 minute? Can I ask how much IUT costs? One procedure?
Okay, in our center, we don't charge any pregnant woman who is pregnant is having allo immunization. Even antenatal follow-up is free of charge for the time being. So we don't charge. Even the one who came from Kenya, we have not charged her anything. It is in the government hospital that we are working. So we give in the public hospital, in the teaching hospital, services are free of charge.
All right. Thank you, Prof. I can see Prof. Chauke. Your hand is up. You can go ahead, Prof.
No, thanks very much, and thank you for the very interesting presentation. I think my question is still following on, I can't remember who just spoke now. So if I look at our setting, for some reason, we don't really do much of intrauterine transfusion. And I think there was a time where we had lots of cases, but of late, I think the numbers are quite less. But when you look at the cost, so also we don't charge patient, pregnancy care is free, but I've realized that just to source out blood for transfusion, it's quite expensive. If I remember well, we've been told that it cost about 11,000 rand. Do you have an idea of how much blood will cost in your setting?
No, I mean, in the National Blood Bank, blood is not going to be sold. It is free of charge. It will be collected from individuals who are volunteer to provide their blood. And we request blood from National Blood Bank. And when they get, they will send us. So otherwise, blood, it is given to any hospital, whether it is private or public, it is free of charge. I don't know. I don't know. Maybe if you share us the experiences of other countries. In Ethiopia, it is free of charge.
All right.
Dr. Veranga, yeah, Prof. Abdulkadir, just a question for you. Probably it's not a question, but a comment. Thank you so much for a very impressive, for the impressive work that you are doing there in Ethiopia. It's very impressive. In my country, the rhesus negative status is probably around 2 to 3%. And of this 2 to 3% in Zimbabwe, is around 2 to 3%. And in this 2 to 3%, the incidence of rhesus isoimmunization is very rare. So that in our unit, we have not come across a case of severe rhesus isoimmunization for the past 2 years or so. What do you think? Do you think this is just geographical difference? And also the uptake of rhesus D immunoglobulin is also very low because it's not available for free in the public sector. Patients have to buy. But our cases of rhesus isoimmunization are very low. So that I'm interested in your population, where is this quite high and yeah.
Yeah, thank you very much for your question. I think in our continent, there's no adequate data to demonstrate the prevalence of RH negativity in our continent because number one, RH status of pregnant women is not going to be determined. Only those who are going to come voluntarily give blood, their blood will be screened. Even in majority of, most of African countries in the countryside, even they don't determine blood group RH status. Okay, even the hematocrit are not going to be determined. In the majority of settings in African countries, in the countryside, this is the case. So I don't know, in Zimbabwe, if it is 2 to 3% from the National Blood Bank that is determining day-to-day basis the RH status, then that is the case. But I don't believe that will be a good it will not generalize the whole Zimbabwean population, because even those that you have, maybe it is the blood bank, the National Blood Bank of Zimbabwe that is giving you these. And majority of those who are living in the city are giving blood, so that can be a difference in terms of mix of the population. So based on my review of literatures, there's no adequate data in African countries demonstrating their prevalence. But I have read from the finding that I found is from 2 to 8%. In Ethiopia, it is between 8 to 10%. One, we are very closely related to these Arabian countries, and Portuguese and Spanish were colonizing this part of the continent. So maybe that can be one reason, because it, as it says, Basque tribe is having a very big prevalence of this Rh negativity. So, that is the reason. Our anti-D is not widely available, you are right, in the majority of, in almost all African countries, not only African countries, even in the middle income countries, it is not widely available. It's available. It is very expensive. So only few rich countries are covering with health insurance coverage. In our country, when you come to our country, when the government is going to import any drugs, including Rh-D immunoglobulin, it will be provided to our patients free of charge until it is going to be finished. Okay, when it's going to be finished, then many months can be waited until others will have a chance to get free of charge. Thank you very much.
All right. Thank you so much.
One minute. Professor, at what point do you give IVIG for rhesus alloimmunized women?
Okay, we don't have IVIG if it is going to be available, very expensive. So mostly if it is going to be provided in the second trimester of pregnancy, when it occurs severe anemia in the early stage, with a mechanism which is unknown, okay, it may reduce destruction of fetal red blood cells. So in the early second trimester of pregnancy, when it occurs severe anemia, IVIG has a place, but in our country, we are not administrating that. If it is available, it is very, very expensive in thousands US dollars. Yeah.
What about steroids? Do you put the mother on steroids?
Yes, we put steroids, especially when we after 32 weeks of after 28 weeks of gestation, when she is at risk of bleeding, fetal bleeding. Always we administer corticosteroids for 4 doses. Especially we use dexamethasone here. We don't have betamethasone, so we administer that. Especially when we think that she's about to deliver within 48 hours or within 24 hours of from the intervention. Yes, we administer. Or at 35 weeks of gestation, amniocentesis, when it is done, if it is immature, okay, we can administer that, and also phenobarbital concomitantly will be started if the multiple of the median is less than 1, or if it is less, we do not administer, and we'll wait another 2 weeks, and maturity will be determined, and then induction will be done.
Okay, thank you. What about prednisolone, or early enough, like if a mother has had a previous history of a poor outcome in pregnancy, to just suppress her immunity before?
Prednisolone, as I told you earlier, if the problem occurs in early second trimester of pregnancy, that can be considered, but based on many experiences of many countries and literature reviews, prednisolone does not have a significant role in terms of maturation of the lung of the fetus as compared to that of the dexamethasone and betamethasone. And effects in reducing antibody production, there might be a place for that, but still studies demonstrated that there is no statistically significant difference whether they used prednisolone or not.
Okay, thank you.
Welcome.
All right. Thank you, everyone, for staying with us for the afternoon session. Thank you, my presenters, Tatenda, Dr. Sisai Kiba, and Prof. Abdulfetah Abdulkadir. Over to the chair.
Thank you so much. I'm sorry that way to go beyond time to allow this very interesting presentation to be pursued to their logical conclusion, because we thought it was important that we hear the experiences of our colleagues from Australia, because we thought it's very important to know what is happening in other regions in our continent. So thank you so much for sharing your work, and I think we're all inspired with what the group of Prof. Abdulkadir is doing in Ethiopia, and we need to learn, and this is an opportunity to know each other, to collaborate, to enrich each other. Certainly, we will ask you to present probably some point again on the issues of indirect and transfusion rhesus ICU immunization, because you have what we will call a lived experience of this condition, really. So thank you so much.